Good afternoon, folks. It's a pleasure to be here, and I'm going to share with you this afternoon my experiences using transcranial direct current stimulation in the motor systems, largely in stroke patients. Over the last 5 or 6 years, I've been doing transcranial magnetic stimulation for about 20 years, actually, and I moved to Boston for a while and got excited about tDCS because of its potential relatively easy use for clinical populations as opposed to the cost and the training associated with transcranial magnetic stimulation. So I've been using it for a while now, and we've certainly done lots of studies both in Boston and mostly actually in New York at Burke Medical Research Institute. So I'm really a motor systems physiologist, and I'd like to share with you what I've done. Tell you my thoughts in the context of today's presentations and leave you with a couple of themes. One is largely combining brain's transcranial direct current stimulation with behavior, and the other is directions that I'm thinking about moving in this field. So the first point here is that transcranial direct current stimulation has historically been given without the brain functionally engaged. We have heard today that tDCS static field has an immediate effect, but also these lasting effects. And while tDCS can positively alter functional pathways, for example, the corticospinal tract, the stimulation is relatively non-specific, even if we focalize it in a specific region. Given greater specificity could be attained by having functional activity interact with the tDCS effects, specifically the during or after effects of functional activity with the during or after effects of the stimulation. And I'm not sure if there's a correct or incorrect, but done correctly, potentially we could improve the after effects by having greater magnitude or longer lasting. But also we could upset the effects by having this interaction, by nullifying the effect completely or reversing the effect or having an adverse effect. So I think that there's merit in this line of thinking, and so do others, because there are papers that are now emerging in the literature on this topic. So I'll discuss a few things here. We've talked about the motor evoked potential, and it's always nice to see, I'm aware that some people in the audience might not be familiar with that. So we'll have a look at what a motor evoked potential is. And this is a transcranial magnetic stimulation coil held above the left motor cortex of a healthy subject. Let's see if this video works. And there's a small click when the button is depressed, and in the contralateral hand you'll see a little twitch, most pronounced in the fingers, not isolated to any muscle actually in particular, but a synergistic pattern of muscle activation according to the area that you're stimulating over the brain. Okay. So this is a basic schematic of how it works. We have a capacitor that discharges very, very quickly, and a current in a monophasic pulse goes unidirectionally, and when held adjacent to excitable tissue, it'll excite that tissue with the field in the brain running opposite direction to the field in the coil. And this, depending on the intensity of stimulation, will indirectly activate corticospinal cells in this case, via a series of what's called I waves or indirect waves that have a synaptic periodicity that then summate in the spinal cord and the alpha motor neurons and lead to a motor evoked potential, which can be recorded by surface electromyography, and you see that in the EMG instrument here. And this is what we're talking about when you see the MEP in the papers that you're reading. And it has various characteristics. You can record the latency, the conduction time, which is usually around 25 milliseconds or so. But typically the peak-to-peak amplitude is one of the most prominently reported characteristics. And that's one of the measures of the excitability that people talk about. And that can change with interventions that try to reduce or increase that. And there's various types of machines that can be used to probe that, even transcranial electrical stimulation, which we heard about this morning as well. So this has already been shown today, and it was quite a pivotal paper showing that we can indeed influence the excitability or the amplitude of the motor evoked potential by applying this electric field, and that what I think is important to note here is that even with these electrode pads, it was montage specific. So it doesn't occur with certain montages, and it does occur with other positions of the electrodes. And that it's also polarity dependent, so depending on which direction you pass the field, you will change that evoked potential accordingly. That this has an after effect, and that after effect is dependent on the duration and the polarity of the applied field. And so it needs to be applied for some time, several minutes at least, in order for there to be an after effect. So just recapping on things you've heard already this morning. But this becomes relevant in my talk a little bit later. So what about tDCS for enhancing motor function in stroke? I'm interested in these motor systems. I'm interested in the evoked potential. I'm very interested in the relationship of the motor evoked potential to function and the debate that goes on about that. But let me give you a bit of a background as to what's happened in this field. So you've already seen this this diagram this morning, which was nice. It's a simplified schematic of a coronal section of the brain, and in this case, it's showing that a unilateral focal lesion, such as can occur in stroke, upsets these excitability properties of that area of cortex. Specifically, it results in the abolishment or the reduction in the output to the contralateral muscle if it involves middle cerebral artery territory. But it also results in a alteration in the effect of interhemispheric interactions of homologous contralesional cortex, and that's been assessed with these two magnetic coils that are held on either side of the head. And so there's been a bit of work published on this, and I've tried it myself, and you can, using a conditioning pulse paradigm, test that pathway. So the thought was, well, if there's a deficit in output to muscles and the person can't voluntarily activate them well, and it relates, and the output, the motor evoked potential is smaller or gone, then maybe we can stimulate any viable perilesional tissue and increase the output to that area, even acknowledging that it's part of a complicated network that ultimately controls that muscle. Or maybe we can target the other hemisphere as well if there's an interhemispheric relationship. And so thanks to Professor Bixen and his elegant modelling work, people use this particular montage most commonly for this, and so most of the work is done there. And again, we just recapping on an earlier talk by Dr. Hamilton. So you can target the unaffected hemisphere, which is also considered to be pathological in that the excitability is increased. I don't think I've ever actually assessed that myself, but there's certainly plenty of literature on that. And the output of the affected hemisphere, which is reduced, so you could target either of those or both of those at the same time, and there was a question on that earlier today. And you could use other methods as well, so people have tried this with high-frequency repetitive stimulation, which also has a excitability increasing effect, or low-frequency stimulation. And so this isn't an exhaustive list of all of the literature on this, and it stops at about 2009, I think. So there's a lot more work that's been done, but it just shows that, and I don't know whether any specific protocol has been repeated by different groups or even the same group twice, but there's certainly a lot of literature in support of this concept. And down the bottom you can see that there was not only an increase in output to the affected muscles as recorded by that MEP and the surface electromyography, but there was a change in behavior that was positively correlated with that. And so that's important. It doesn't mean that MEPs and excitability always correlates with function. It just means that in these studies, the behaviours that they chose in this patient population did correlate. And so that's really, and I found a similar thing with these kind of patients using different methods of behaviour. The typical behavioural improvements, these functional improvements here, simple and choice reaction time, pinch force acceleration, active range of movement of the fingers and thumb, movement accuracy, a pegboard test, a Jepson-Taylor test of hand function, accepted measures of voluntary motor control in this group, and correlates of the with a transcranial single or sometimes paired pulse excitability measures. So then, more recently, there's a couple of meta-analyses that have come out and said, well, let's have a look at all of this data and see whether there's merit to this. And I don't know how much value you'd put on either of these individual studies, but certainly they both point in the same direction, that that this kind of stimulation, where you have stimulating the perilesional area with an anode over the top of it using an electrode pad and a cathode, usually supraorbitally, appeared to have a positive effect on behaviour in stroke survivors. Predominantly, these studies were done at rest, and so there's limitations potentially with doing it at rest, and in that the effects are fairly short-lived, and they're not a panacea, obviously, as well. They don't completely cure people; they just move them in the right direction.
Can I ask a question? So when are people being tested relative to when the stimulation is in these studies?
I think that's a really important question, and I hope I come back to that at the end of my talk, but it's very important, because in motor learning literature, sometimes early effects that you see after a learning paradigm are negative, but they're the ones that you want, because later they consolidate to something that's really important and positive. So that it's different for different groups. We typically test it immediately after and then wait some time, but in the order of an hour or so, maybe 2 hours, to try not to keep the experimental session too long and have confounds there. Others test it that afternoon, the next morning, the next afternoon, the next morning. So some people have really followed it a long time. For our clinical studies, we follow the assessment right out to 6 months. So one idea might be, if you want to have a lasting effect or a greater magnitude effect, is to do it more frequently. And so there's some evidence that applying this over multiple sessions can have an effect that lasts for a longer period of time. It's not limited to 1 hour or 2 hours. So one of the thoughts that I had was maybe we could use repetitive behaviours and couple this with the therapies and have potentially a more specific effect and maybe a more enduring effect, rather than applying it in a non-specific functional context. And it's just a hypothesis, but we've been testing that. And the first thing I thought that we need to do is work out how repetitive behaviour might actually affect motor cortex. So I'm talking about the motor systems. You might work with other behaviours or cerebral networks, but I think there's some parallels that we can draw here. And why am I interested in behaviour? Why don't I combine pharmacology with tDCS? I picked behaviour, I guess, because of my background. I've studied a lot of various types of motor training paradigms in healthy subjects, and acute neurological damage and neurodegenerative disorders as well. And to me, it's one of the most in terms of motor learning, it's doing something repetitively that's goal-directed with meaningful feedback and progression is one of the most compelling methods of advancing that behaviour. And so we know that it works, and we know that it's enduring. So it seemed logical to combine that with tDCS. But I thought we'd better understand the behaviour very well first if we want to combine it with this stimulation. And there's various things that happen when you do motor behaviour repetitively. There's structural changes, and this is just one study picked out of many, and a study showing that even in an hour of repetitive activity, you can have these dendritic spine formations that later consolidate and prune, etc., over subsequent days. But there's structural changes occurring very early on. There's physiologic changes in animals and in humans that have been shown with evoked potentials. And there's debate as to how they change and to what circumstance these physiologic changes occur. And some people argue that you need a skill context for these motor maps in this case to change, and others have shown that you don't need a skill context, you just need repetitive activity by itself. And there's reviews on this, and some people have a look at endurance training versus strength training versus skill training. But certainly the ability to evoke a response at a spinal level or at a brain level can change according to this repetitive behavioural activity. And that repetitive behavioural activity is known to be associated with adaptive changes in behaviour or skill learning. To look at it in a little bit more depth, I quite like this study by Klassen and colleagues, where they just did a single pulse of suprathreshold magnetic stimulation and observed the hand twitching like in that first video that I showed, and they put an accelerometer onto the thumb and recorded a series of these suprathreshold pulses with the intent of determining which direction the thumb was moving in, and it typically moves in a consistent direction. And they quantified that, and then they asked the person to train with these ballistic thumb movements in the opposite direction to that. And then after this training period, they stimulated the cortex again with the person at rest, and the thumb started twitching into that new direction. So it was some evidence of this early encoding in primary motor cortex of this repetitive activity, and over time that recovered over the next hour or so to start moving in the original direction again. So we know that primary motor cortex is implicated. We know that TMS can assess the changes. Not only are the changes in excitability important in their own right with the MEP, but they somehow relate to this functional change or directional change in this case of the thumb movement. And to me what that means is changes in synergistic patterns of agonist and antagonist muscles must be happening with this during this training period, and they must be occurring right there in the primary motor cortex or somewhere in that pathway at least. The thumb's a little bit complicated to study in that sense, to work out what different muscles are doing. So we decided to have a look at this in the wrist, in the forearm muscles, where the antagonist-agonist relationship is a little bit better defined. So we did the same thing, just using a goniometer strapped to the back of the wrist. And contrary to what you might think, when you start training in the opposite direction to the direction that you're twitching in, you do start to then twitch in that new trained direction. But it's not because the muscle that you're training becomes hyper-excitable. In this case, it does a little, but it wasn't significant. But the antagonist muscle, the muscle breaking that movement, becomes inhibited. So the MEP is markedly reduced in amplitude to the opposite muscle. The point of saying this is, in this case, what kind of brain stimulation are you going to do to that region if you want to enhance this training effect? The natural thing is, what you'd be imagining, my guess is, if we did a show of hands, which we won't, is that you would say you should do anodal stimulation in some temporal relationship to that training, and you'll get a better effect of moving in that new direction, because the muscle that you're training will be hyperactive or more active. But just this example shows that it's not that simple. Maybe we still would do anodal stimulation, But we're really after, if we really want to exaggerate this effect, maybe we want more inhibition of the antagonist muscle, and that's what we should be targeting. And here is a great example, because these muscles are, the representation overlaps like this, right, in terms of the corticospinal origin. So it might be a nice, and so that shouldn't scare us, because we can functionally get at one of those particular muscles by somehow combining the brain stimulation with the right kind of brain stimulation with the right kind of training, even though we're stimulating exactly the same area where all of these neurons originate from. Okay, a little bit on robotics. So here is a wrist robot at our clinic in New York, and they're the MIT Manus robots. Not only are they good for training, but they're great for assessment. In fact, that's why I started using these devices in the first place. I didn't know what they were like as a training rehabilitation tool, but I really like their ability to quantify human performance better than a clinician's eye could, or a clinician's qualitative judgment. This is the kind of they're trying to hit these targets in all the different directions. Some of those directions are difficult because they have reduced ability to move that limb after they've had their stroke. You can see here a pre-training attempt at trying to hit all of these different directions on the clock face, and then after about 6 weeks of training, you have a much cleaner ability to hit those targets. And there's some other metric. I mean, this is visually appealing because it's very clear as to how these people improve, but we go into much more detail of that, about the quality of movement, not just the range of movement, for example. So they're a great assessment tool, and there's a long history of publishing. So reviewers really like this as an assessment tool, because we can point to a lot of different papers in stroke and Parkinson's disease and spinal cord injury, etc. What about robotic devices for actually training? So it's not the focus of my lecture, but I want to just touch on it for those who are interested. So regardless of the behavior that you're interested in, I would imagine that seldom, when we want adaptive plasticity, do we passively attend to environmental stimuli. More frequently, we want the person to respond to those stimuli and do some kind of volition, and do that repetitively and adaptively. So you could probably think of this for other types of executive brain function behaviors as well. But certainly in the sensory motor systems, we want the person to be actively engaged in that behavior if I want to have a positive interaction between tDCS and the behavior itself. And so robotics is kind of an appealing term for, in this day and age with technology and moving forward in the physical therapies. But it's still a bit nebulous, and so people argue about what it actually is. And so here you can see different kinds of devices. The top left is a passive movement device. Like after somebody has an orthopedic injury, they might be put on one of these devices, and the person doesn't do anything, they just lie there at rest. This is an isokinetic dynamometer that you see in movement disorders clinics. This is an exoskeleton device from California here, and this is a treadmill with a bodyweight support. And with the exception of the upper left, I think all of these are called robots in the literature, and they're not really. And they require different amounts of the person to interact with them. So I have kind of Dylan Edwards' definition. It should really be an intelligent, powered exercise machine that it typically involves a visuomotor task, but not always, like these Iron Man suits. They don't have a visual component. The person just tries to walk. But often they involve the person looking at something and interacting with something on a screen. But it has to be performed repetitively. It needs to be able to sense what the patient's doing and provide suitable assistance. It should back off as the person starts to improve. And it's got to provide feedback. With learning, we know that we have to have feedback, and it should really provide the knowledge of result, which means how many trials did they get correct, and ongoing knowledge of performance. So as the person's doing the behavior, am I doing well? How am I going? And these, this is well-published stuff in the learning literature for motor learning. These things are really, really important. Well, this is an exoskeleton device. This is a person who's completely paralyzed from the lumbar cord down. So they've never been able to walk since their injury. I think it was a snowmobile accident. This is at the Scripps Institute in San Diego earlier this year, perhaps. And it's a great tool because the person can use it as an assistive device, and we're trying to use it now as a rehabilitation device, but just to show you how it works. So this person can't stand up by themselves, and they certainly can't walk. Is this thing working? So it's got sensors about how the joints are moving, what angles they're at a current time, how much work the person's doing, how much work the robot's doing, and it will move them through a normal gait cycle. So great for their self-esteem and autonomic and blood pressure, orthopedic things. Not really so good for rehabilitation yet because it needs to have those other parameters that we're talking about. But we think this could be a really useful tool. This one, and these are expensive. They're 100 to 200,000. This is about, I think, 2 to 300,000. It's a Locomat, and it's the same kind of thing for driving limbs in a gait-like pattern to try and rehabilitate people who can't walk for various neurological reasons. So this is a big area of interest at the moment for us because we're trying to think about how we can use DC stimulation to augment gait training. Do robots even work? This is probably the best paper published that I've seen. A VA trial that was run. I think one of the few studies that's ever been, probably one of 2 studies that's ever been published in this journal on rehabilitation. But it was nebulous. I had to give a position lecture on this paper, and I think it was difficult to read through for me, and I looked at it in detail. So I imagine what everyone else is thinking, and we're writing a letter to the editor at the moment about this paper. But essentially, they didn't show that upper extremity robotics. They didn't prove their primary outcome, which was, does this robotic system improve upper extremity behavior in stroke patients better than physical therapy? At 36 weeks, which is 6 months later, at 36 weeks, they had a comparison again with these different groups. They had a usual care group and an intensive therapy group and a robotic group. And the usual care and the intensive therapy and the robotic training group were significantly higher than the usual care group. I mean, this made a big difference to these people's ability relative to people who didn't get involved in this therapy. But if you did manual therapy for the same amount as the robot, you could get the same effect. So are robots effective in that sense? Yeah, they're really effective. Can a human do the same thing? Yeah, a human can do the same thing, but it breaks your back to try and do it that amount of times because human therapists do this behavior about 60 repetitions a session. The robot does 1,000 repetitions, so the therapist has to do like a huge extra number of repetitions per session. Repetition's important. Who's it best for? It's probably not that robotics are probably not good for people who are completely paralyzed because there's not enough biological substrate to work with, and that's why there's been, I think, a lot of failed trials in these complete spinal cord injuries. People who are really reasonably high function already at this end, they probably don't need these expensive devices for therapy. They can do other things, so there's probably an optimal range in the middle. Does the type of training matter? Well, I think it does. If you do continuous passive movement, it doesn't help motor control. It has some orthopedic benefit, but doesn't tend to help your ability to volitionally control. But I published previously that even passive movement, like that passive movement device we saw for orthopedic benefit, it has a profound and immediate impact on the central nervous system. So yes, it doesn't help people to regain human motor control, but it does really influence the amplitude of the evoked response. Has a fluctuation according to the range of movement that's being done and a passively moving limb. when the muscle is being stretched, the MEP goes really small, and when the muscle is shortening, the MEP goes really big. So there is ongoing modulation at the sensory nervous system level from this incoming afferents, but it doesn't appear to have this strong effect on motor control. So I don't think we can ignore it. How to build that in with tDCS, we're not sure yet. So the idea is, can we couple tDCS with training, and is that a good idea? And so no one was really doing this in the early 2000s, I guess, and then there's been more of an explosion about the idea of this in the literature in the last 5 or so years. And people thought, well, if doing this behavioral stuff is good, and if doing tDCS at rest is good, then surely if we combine them, we're going to get a really good effect. And so initially I thought, well, maybe we will. But, you know, if motor training has this effect X and tDCS has this effect X, if we combine them together, what do we expect to get? And I wasn't so optimistic that we'd automatically get double the effect or an augmentation of the effect. We might not get any effect. And this, and I thought that this was based reasonably on some physiology at the time. And so there's a few papers that have shown this kind of thing, but I want to just highlight 2 of them. Here is a paper that has combined RTMS and tDCS. So RTMS is repetitive transcranial magnetic stimulation. And in this particular paper, they did not use a RTMS protocol that has a really profound effect on the MEP amplitude. It has some subtle interneuronal effects, but it doesn't affect the MEP by itself in the way that they've used it. So we know that it generates synaptic activity in the cortex because it changes these paired pulse TMS paradigms I won't go into. But it doesn't itself change the MEP. The tDCS, we know that the anodal tDCS has MEP here on the vertical axis, and anodal tDCS by itself will increase the amplitude of the evoked response, which you've seen already this morning, and while cathodal will decrease the amplitude of the response. And here is the 5 Hz RTMS by itself, which has intracortical effects but not net effects on the MEP, just reiterating that. But if you do this relatively benign synaptic activity in the cortex after a period of tDCS, instead of having this prolonged after effect, you have a dramatic reversing of the effect because of this synaptic activity. So in this case, the after effect of the anodal turns to more of a cathodal effect, or reduced below baseline, and the reversed for the cathodal. That means that synaptic activity in the brain, in some temporal relation to tDCS, can change the effect of tDCS. Synaptic activity is precisely what happens when we do behavioral exercise. That was one example, and that, looking at that, I thought, wow, we really better understand the physiology of the tDCS, the physiology of the behavior, and look at how they interact systematically. And this was another study by Dr. Nietzsche, who I really like this study as well. And let me just explain the difference between the top graph and the bottom graph. This is looking at anodal versus cathodal stimulation in relation to paired associative stimulation. So it's another non-invasive stimulation paradigm where a single pulse at the cortex, a single pulse usually on the median nerve or the ulnar nerve, timed specifically to have an effect at the level of the cortex on the evoked potential amplitude. And in this case, it was an excitatory protocol whereby after this paired associative stimulation, you'd expect the MEP to grow. And after anodal stimulation, you would expect the MEP to grow. So on the left axis in the top, we have, this graph shows what happens if you combine anodal tDCS and excitatory PAS with the tDCS preceding the other intervention, the PAS. And if we do that, or as it was done here, you see quite a marked increase in the amplitude of the evoked potential. And actually, they noted in the paper, larger than what you would see with either intervention alone. So a clear augmentation of this excitatory phenomenon. So two excitatory protocols, one preceding the other, in this case the DC field preceding the PAS, one having synaptic effects and the other having synaptic after effects, but different effects during the stimulation. And it has a clear, well, who's to say that this is positive, but if the aim of what we're trying to do is increase the amplitude of the evoked response, it's clearly more potent in this circumstance. If they did cathodal and PAS here, then the PAS no longer had a positive increase on the amplitude of the evoked response. In fact, it went negative for some time points here. Now, the bottom graph shows if you did this concurrently, and it gets to one of the points I'm trying to make in this talk. So if you do the DC field and the synaptic activity concurrently, here you would have a negative effect from anodal and PAS combined. So remember separately that they both increase the amplitude of the MEP. So it's switched to a negative effect. So I don't know whether we can, I don't know how to extrapolate this behaviorally, but if we do concurrent tDCS and behavior, we might get not an augmentation effect, but an opposite effect, versus if one precedes the other. So I think that's really intriguing. And I'm not going to try and make any rules here during this talk, but I'm just going to highlight the fact that it does seem to matter, certainly from these elegant studies, about the temporal relationship of synaptic activity, very well controlled synaptic activity in this case, to the application of the DC field. So I've looked at it specifically relating to the study that the robotic training that I've spent a few years on now, and I thought that was important. I thought we probably can't make these general rules and say that all behavior, regular learning and memory, or even a different kind of motor behavior, will hold true for things that I'm proving here. But certainly I'm really interested in relation to upper extremity robotics, because that's what we spend, my therapists at work spend a lot of time doing this, so we have to pay a lot of attention to it. So I had a look at what happens when somebody does this robotic training after a period of anodal tDCS in stroke patients. So we did, this is pre-tDCS, this is about a 1 millivolt amplitude evoked response from a suprathreshold TMS pulse in the affected perilesional area of stroke patients. We applied the anode over that region, the cathode supraorbitally on the other side, and the evoked response got bigger. We then did the robot training, which lasts for about 45 minutes. And I really didn't know what would happen, whether we would have lost the effect. There'd be some interaction where we lost the effect of the increase in amplitude. And what we found was that the effect of the robot training and the effect of the tDCS could coexist clearly here, because the MEP remains the same amplitude. It looks a little bit bigger here, but on average it's the same across that training period. So the after effects of anodal tDCS in chronic stroke hemiparesis can be sustained during a period of robotic training, which is really important for us to move forward with this combined therapy. And here's the group data showing that it has the same behavior. Importantly, it was associated with a reduction in short interval intracortical inhibition, which was of interest to me. This was done in 2008 or so, and around the time Zeman in Germany had shown that if you can reduce intracortical inhibition, you get better plasticity relating to the excitability of a motor map. And so we thought it would be nice if we could have a protocol that would reduce intracortical inhibition and be more permissive to plasticity that we're trying to promote. So that was that, and this is how, and this was funded by NIH, and then we got excited about doing anodal tDCS prior to this kind of robotics training in stroke patients. we didn't know anything about the behavior at this time. I mean, is this going to be important behaviorally? So we thought we'd better have a look at the performance of the patient, because it could be independent of the performance of the patient. So in 12 chronic stroke patients with some weakness still in the wrist extensors, they embarked on this protocol where we looked specifically at the timing of application of tDCS. What happens if we did it before or during or after this period of robotic training? We used this paradigm where they just moved into their direction of movement that they were finding difficult, which was wrist extension of their affected hand. And they just looked at this visual cue on the screen, and they had to try and move from the central position here to extension, and then the robot passively moved them back to that central position again. So importantly here, the training paradigm was precisely the same time as the stimulation paradigm. And I say importantly now because I'm trying to dissect, I don't know how many tens of papers about combining therapies with tDCS. And typically, the therapy session lasts longer than the stimulation period. So even when people say they were doing therapy and stimulation at the same time, well, it was never really at the same time, because the stimulation only went for 10 minutes and the behavioral practice went for an hour. So it's but in some cases they did go for precisely the same time. I think in that Reese study that was presented earlier, they were at the same time. So I'm trying to dissect that at the moment, but in this case it was precisely the same time for the practice and for the stimulation itself. So we looked at whether sham or under which condition was better, and we looked at these various metrics here about how the person moved from one target to the other. You saw the squiggly lines from the robot before. But thanks to a lot of work that had been done at MIT, we collaborate with them and we use their robots. So they'd previously published that in stroke, out of a heap of different metrics that you can examine, these 5 were highly correlated with clinical function. So we honed in on these 5 metrics. And out of these ones, it was the movement smoothness that was the most highly correlated with clinical function. So it wasn't actually the active range of movement or the deviation from the line, how accurate they were in that sense. It was how jerky they were. Okay, so this is a little bit of a busy graph, but it shows, out of those features that we were looking at, what happened when we applied tDCS at different time periods. So first of all, have a look at the one on the left of the screen here. So if we did no tDCS, actually they thought they were getting tDCS, it was sham. The patient started preferentially moving faster. If we then applied tDCS prior to their robotic training, we found that they evaluated after the training session, the patients were moving. They weren't moving faster anymore. They lost that sort of preferential increase in movement speed, but they'd substituted it for moving smoother, which was a kind of a weird thing to see, because movement smoothness is a tricky component of voluntary behavior in these patients to get, and it typically takes multiple sessions. So it's quite an advanced behavior. And so this change in movement speed was substituted for this significant improvement in smoothness of around 15%. When we delivered tDCS during training, there was no positive effect, and they got worse with their aim. And similarly, we delivered it in the post-training period, there was no positive effect, and they got worse with their mean speed. So how do you interpret these data? Well, interpret it how you will, but it seems like tDCS did something. It mattered when you delivered it. The most poignant and adaptive combination appears to be when tDCS was delivered prior to the training. Now there's a few caveats here, obviously. This was one single training session, and we assessed it immediately after the training period. So what happens if we assessed it the next morning, for example? But it's certainly consistent with our physiology results in that's the preferential time to do it for this combination of training in this group of chronic patients. So of course now we're looking at whether there's a much more grand effect if we do that combination over multiple sessions. And so we're funded until 2017 to follow this up and not just do it in a single session, but do it over 36 sessions over 12 weeks. And so we have this training paradigm that's a lot of work, but we're sort of a year into this at the moment. We evaluate these people 3 times before they start. We make sure they're stable in 3 different measures: clinical, kinematic, and neurophysiology. And then they come in 3 times a week. They get brain stimulation, then they train on these robotic devices, and then after the 12 weeks, they come back the next week and they get evaluated on all of those items again. And then they come back 6 months later without any significant intervention in the meantime. So it's a pretty big exercise, and the epidemiologist has said that we're not powered sufficiently to make any statements about the effect of this yet. We've done around 25 patients already, so that's a lot of 36 by 25 patients. It's a lot of sessions. It appears to be really well tolerated. Patients in both groups are improving, so there doesn't appear to be any negative effects of this combination. One thing is quite clear, that some of the patients in the stimulation group have had phenomenal improvement. I mean, we normally expect about 4 to 6 points change in the Fugl-Meyer scale, which is our primary outcome, and we're getting up to sort of 14 or 15 points change, but others are not. And so I think the whole study is going to be quite a different outcome than what I predicted, and we're going to have to quite carefully look at those people who are responding and those people who aren't responding. And I think whilst nobody is having a negative effect, and that's really positive in terms of worry about whether this is going to negatively affect people, I think that we need to be a little bit more careful in looking at which patients are going to respond and which aren't. And here's a picture of the clinic, and it's a pretty busy place, and you're welcome to come if you're ever over in New York and see it in action. And we're doing the pad electrodes in the same montage that we've kept consistent. The same training, the same group of patients, characteristics, and the same robotic training. So we're not going to have the final results of this until we have the same consistent groups to begin with, and that's going to take a few years because of how people are randomized, etc. But there are other studies that show both positive and negative effects, and I'm really interested in these. I'm particularly interested in these because it's a lot of work. It's one thing to run the first study that I showed, where you bring people in and do a cross-sectional study in 12 patients, maybe with a few different, you randomize them to get sham or real. You can do that in a month or 2 months, but these other studies where you're doing multiple sessions, they can take years, and they cost a lot of money and they cost a lot of time. So I'm really intrigued as to understand how to make sure that we're onto something before people go along and embark on these kinds of studies. And to look at what other people have done, and if they did work, try and find out why they worked, and if they didn't work, try and find out why they didn't work. And so here is a study that came out this year, and it was already been described today, and showed that there was a positive effect by either stimulating the affected hemisphere or the unaffected hemisphere separately. And interestingly, they did tDCS and then the training. In the same kind of combination that I did. There was a study that failed by Hesse in a multi-center study in Europe, and I'm interested to know why that failed. They were earlier stroke patients for a start. They did the training and the stimulation concurrently, and they did bilateral training and unilateral bimanual training and unilateral stimulation. So there's a few factors here that need to be dissected, but clearly under some circumstances it's working, and in some people it's really working well. And so we just need to get to the bottom of that. So I'll summarize by saying that tDCS can be given with the brain functionally engaged. And I'm very interested in doing that, not only for motor systems, but I'm interested to work out how it's being done in speech and language, and we're embarking on a study doing that, and even for depression studies. I can imagine that people would be maybe combining these cognitive behavioral therapies with stimulation, or at least controlling the environment in a certain way. So I think done correctly, tDCS after effects can be potentiated, further lasting, and maybe more specific. I'm not sure if there's done incorrectly, but it's potential that the after effects could be reversed or adverse. And I haven't even touched on that today, but it's of course completely plausible that we can have maladaptive plasticity using these techniques. Or they could be just different as in we saw. I mean, we weren't. I wouldn't have predicted that if we did this robotic training and the people were moving faster, that we'd have something different that occurs when we apply tDCS. I would have thought that we would just scale that effect of speed rather than having a transformed effect. There's something a little bit more advanced. So I think that the matrix of different tDCS and behavioral variables needs to be systematically tested, and I'm doing that using my paradigm, and that's something that's going to be a bit of work over the next few years, but I think it really does need to be systematically tested in order to work out the timing of application, the dose, and really in relation to the behavior, because that's just as important as the stimulation itself. So are there any rules for combining tDCS and motor training? Well, in this particular patient group tested at these time points, doing the behavior that we did and the paradigm that we did, it was clear that tDCS preceding the behavior was better, and that tDCS during the behavior was worse. But is that a rule for other kinds of behaviors in tDCS? I wouldn't be going to say it, and I would suspect that it really matters on the type of on these different variables. I mean, there are some rules that are coming out about tDCS, like the montage is important. Certainly the stimulation duration is important, and the intensity is very important. So we're starting to learn that, and we're starting to learn how it differs in different patient populations. There are certainly rules about motor training. We know that it has to have repetition, just like learning. You can't do something typically once. It needs to be done over and over again. There's various rules for motor training. So we're slowly starting to piece together these rules, but it's not a recipe that I can actually give out in this kind of session where you can say, well, we must do this, even though we're trying to improve hemianopia in stroke patients. I wouldn't say until it's systematically tested whether the things you've seen here today apply. Where to from here in my final seconds is, well, one idea is, and someone brought this up already today, is if you're giving the same thing at the scalp, it means invariably that people are getting something different at the level of cortex of interest when you're delivering this tDCS. And so we're getting great insight into how to deal with that. So one idea maybe to reduce inter-individual variability that we're seeing is to have a little bit better to know a little bit better where we're stimulating and the exact current density in the anatomical region of interest. But be careful what you wish for, because the elegant modeling work will now give you the ability to be able to do that, and then you have to know what you want to do as a result of that. And so we've been having a look at which areas of the brain we might want to target if we can really reduce it down to a single gyrus, and which part of the gyrus we might try and stimulate, and what kind of current density we might apply. Does that differ for people with small lesions versus large lesions? And it probably does. Or maybe the idea of getting away from a single focus anyway and targeting a distributed network where you're looking at stimulating maybe 2 different nodes or more than 2 different nodes concurrently. Another thing that I've been thinking about is I noticed this with a protocol called ITMS. I was part of this paper a few years ago where it's a pair of pulses that is given at a synaptic periodicity of the 1.5 milliseconds. And at threshold level, 2 pulses will summate and have a nice size MEP. And done over time, I think it's about once every 10 seconds, you get a slow increase of this of the single pulse MEP. What's the point? So the nice thing with that is that during the intervention, you can see how excitability is changing because that MEP changes. And one of the things that I noticed looking through individual data is that it's not kind of this linear thing with linear increase with time for anyone. It rolls like this over time. And then the whole group average kind of rolls a little bit depending on how many individuals you've got, etc. But what it alerted to me is that during an intervention, people's brains are responding with different time courses. Almost everybody responded, but they didn't respond in the same time course. And if you left it long enough, people start to decrease. So it's like these homeostatic mechanisms are more potent in some people or respond earlier in some people and oppose the very intervention that you're trying to do. So where that's leading to is that if you had some way of having real-time monitoring of how someone's brain was responding to the stimulation, you could plausibly terminate it at a defined criteria that would probably be a different timing of stimulation for everyone, according to how their brains respond. And this is speculation, but it's something that I've been interested in and I'd like to potentially follow further. So, all right, well, this is the beautiful campus where I work, and it looks like a sleepy little campus, but we have about 500 stroke patients a year come through, and it's a great place to work. We have a lot of collaborators, and so thanks once again for inviting me, and I'll stop there.